So that's that, folks. See, the idea is when you do NBME, you don't have to get every single question right. You know, the total number of questions for your exam is 280, right? Approximately. You don't have to get 250 to pass. I think if you get more than even 150 or 160, you pass with a high grade because it's a 2 standard deviation. So you don't have to. The idea is every block has 40 questions. You're expected to get 30 right, then you shouldn't have any problem. Does that make sense, folks? So you could miss 10 questions in every block. So that's why, you know, you don't have to get every detailed question right, okay? But this is there, folks, okay? So that's that. Now, any questions? No, okay, so that's about the muscle type fibers and stuff, okay? Now, I'm gonna go to these 2 topics here. Let's go here before we go to the lower extremity. Medial epicondyle. So let's talk about anatomy. So what do we call these muscles here? These are flexor muscles. These are extensor muscles. Those are posterior. Does that make sense? If I want to do flexions, I need my flexor muscles. If I want to do extension, I need all the extensor muscles. Now there is a 2 area in here. We call this medial epicondyle and we call this lateral epicondyle. Both are part in your elbow. Is everybody clear, folks? Now, all the flexor muscles, this is important. All the flexor muscle comes from the medial epicondyle. So all the flexor muscles are developed from medial epicondyle, okay? So every time I am doing this, my flexor muscles are contracting, which means it's adding a tension in the medial epicondyle. Is that clear, folks? Now, anytime I am doing extension, I'm using the posterior muscles, which comes from the lateral epicondyle. So that's the idea, folks, okay? So flexion, medial epicondyle, extension, lateral epicondyle. That's a normal anatomy. Now there is a disease, what we call medial epicondylitis, right? When we see medial epicondylitis, another name for it is golfer's elbow, okay? Not necessarily you have to do golf to get that disease. The idea is anything that causes repetitive or strong flexion will cause golf elbow. Is everybody clear, folks? That's the idea, okay? Now, if you see, it's pain near medial epicondyle. They said when people play golf, and especially in this hand, when they're holding the golf stick, they add so much pressure to the hand here, and that adds that stress. See, anytime I do flexion, the muscle is pulling here. So that's the idea, okay? Now, you don't have to, again, play golf. You could do any activity. There are so many other sports that can cause golf elbow, okay? That can cause golf elbow, folks, okay? Now, the same thing, lateral epicondylitis is when they do repetitive extension, backhand shots. When tennis players play, they're doing backhand shots. For the backhand, if you see, you need such a strength of the posterior muscle because that's the one that adds the power, right? When they do that, they're using so much of backhand that pull the lateral epicondyle. Is everybody clear, folks? Now, when they pull the lateral, we call it tennis elbow. Does that make sense? So again, not necessarily tennis. There are so many other sports. They do that. I heard that even a baseball can cause tennis elbow because it's all about how much you are doing it in the extension muscles, okay? So just to remember, anything that causes more flexion or stressful flexion is medial epicondylitis. Anything that causes extension, that's tennis elbow or lateral epicondylitis. Are we good with that? All right. Come to that. Let's go to this. This picture seems to be a difficult one for people. Okay. It is a full of memory, but there's a small trick you could understand, which is making easier to memorize, okay? So first, what you guys need to do, I'm gonna write here. Forget about this picture or anything, let's talk about. Anytime you take a nerve, each nerve has proximal part and distal part, okay? Each nerve has proximal and distal. Now, let's talk about a median nerve, okay? Imagine in my hand, I have a median nerve running like this. When I say proximal, closer to my head, closer to the body. Is that clear, folks? Distal mean away from the body, okay? Now, the best way to remember any nerve, it doesn't matter, median nerve or ulnar nerve, or it doesn't matter any nerve. But of course, we are talking about upper extremity. Anytime, if you have a lesions in proximal nerve, okay? Again, I'm not specifying the nerve. Anytime you have a proximal nerve lesion, it's very hard to make flexion. Very hard to make flexion, okay? Flexion is problematic. Is everybody clear, folks? Anytime you have a proximal lesion, you cannot flex. Anytime you have a distal lesion, you cannot extend. This is first you need to learn, basic. Okay. Now don't look at the book. Now, in my hand, if I want to do flexions, what is this? This is flexion. Is that clear, folks? This is extension. Now, tell me, what nerve did I use now? I flexed first 3 and possibly a little bit of half finger. So I use my median nerve. Is that clear, folks? All right. Now, imagine if I have a proximal lesion of the median nerve, okay? Proximal lesion of the median nerve. I should be able to do this and my hand will look like this, which means I cannot flex the first 3.5 because it's a proximal lesion of median nerve. Because whenever you have a problem with proximal lesion, you cannot flex. Is that clear, folks? Now look at this first one. This person has a proximal median nerve damage and they cannot making a fist because in order to make a fist, they need to flex. Is that clear, folks? Okay, so the bottom line is to memorize this, folks. That's the most important and helpful. Proximal lesion is always a problem with flexions. So again, here I have no problem with ulnar, so I'm able to flex half of the fourth and the entire fifth, but the first 3 I cannot flex because I have a proximal medial lesion. Is that clear, folks? Can we apply the same theory to ulnar nerve? So if I have a proximal ulnar nerve lesion, I have no problem to flex first 3.5, but I cannot flex the last 2. Is that clear, folks? That's this one, proximal ulnar nerve. Look at that. They are flexing the first 3.5. They cannot tell. Is everybody clear, folks? Okay, so that's the idea. So proximal nerve lesion, difficulty flexion. That's a fact. If you don't get that, this won't make any sense. Iman, good? Okay. Anybody has any issues so far? Now, anytime you have a distal lesion, you cannot extend. So let's pretend I want to extend all my 5 fingers, but I have a distal median nerve lesions. That means I could extend this finger and half of this, but I cannot extend the first 3. Does that make sense, folks? That's, I could tell, distal median nerve. You see that? When you have a distal median nerve, I cannot extend. Is everybody clear, folks? Same thing, if I have a distal ulnar nerve, I cannot extend the 4th and 5th. Is that clear, folks? Right, that's this. Okay. Now, I don't want to confuse, but nobody can ask you by just showing a picture which problem is this. Because if I were to tell you, doesn't this both picture looks exactly the same? Right? So that means this is for you to understand, but nobody can ask you by just showing the picture because that picture should be either distal median or proximal ulnar. Does that make sense, folks? So you don't need to look into the picture, but understand this and you come up with it. Okay, so that's it. So if I tell you, I have a hard time making a fist, I'm able to fist it that 4th and 5th, but not the first 3. Where's the problem? Type it up. Don't look at the book. I want you guys to think. I'm not able to fist your hands, but the first three. So which means my fingers are like, this is of my hand. I'm trying to close, but it's like this, which means I have no problem with me, ulnar nerve. The problem is median. Is that clear, folks? So I'm trying to flex, but I'm not. So where is the problem? I'm trying to flex, but I cannot flex. That's a proximal median nerve, right? Proximal median nerve, because I'm trying to flex all 5 hands, but I'm able to do the 4th and 5th, but not the first 3. Is that clear, folks? Okay, now the second one. I'm trying to flex all 5. I'm able to do like this. Where's the problem? I'm trying to flex all of them, but I did the first 3 fingers, but not 4th and 5th. That's a proximal ulnar. Is that clear, folks? Remember, flexion is a problem of proximal. You have to know that. And then depends on the finger you pick the nerve. Is that clear, folks? Now, last one. I have closed fist. Now I wanted to open. That means I'm trying to extend. I'm trying to extend. What is this? What nerve is that? That's a distal ulnar, okay? Because remember, my hands are flexed. Now I'm trying to extend. Extension problem mean it's a distal nerve. Is that clear, folks? You have it right there. Distal is extension problem, but I'm able to extend first 3. I'm not able to extend this, so that's a distal ulnar. And the other part, okay? I have a closed fist. I'm trying to open. This is all I have. Where's the problem? Distal median, right? That's distal median. See, folks, that's all this hand distortion, nothing else there. Okay, they just make it difficult, but it's not. But if you don't have this chart, that's a different language. Okay, so remember that.
How would they ask these type of questions?
Oh, the same thing what I just told you. The patient is trying to making a fist, and he's having a difficulty fist because the proximal or the first 3 fingers he's not able to do, or they would even say the ring finger is not working. Something they would give you enough hint. Okay, you would know what function they are trying to tell you, but the most of the time student misses this part. If you have a proximal lesion, no flexion. If you have a distal lesion, no extension. Is that clear, folks? If you know that, you would not miss anything. Any other questions? Okay, now let's go to, where's the, okay, before we go like this one, this picture, because I wanted to just make sure this one particularly, this and this, these 2 are important. Now, there's a nerve for lower extremity is called common peroneal nerve. Common peroneal nerve is also known as fibular nerve. A lot of students didn't know NBME uses fibular. They don't use the word common peroneal. Okay, so they use the word fibular. It's very important, folks. Now, when it comes to common peroneal nerve, there's 2, superficial fiber and a deep fiber. In superficial, it takes all the sensory of the dorsum of the foot, okay, except the web space between the hallux and second digits. Imagine if this is my foot, it's the first one. They don't take the sensation on this area, okay? They don't take it. See, that's why it takes, except the first and the second digits, folks, okay? Now, who takes that? Deep peroneal nerve take the sensory on the web space between hallux and second digits, okay? So that's a tricky, you must know that for the exam, okay? They have to know that, okay? So that's one clinical concept. Second, if you see in here, sometimes the lateral part, it's the lateral, okay? This is outside, this is inside, okay? That's outside and inside in this picture. Question will tell this person was playing hockey, something, they got hit or some damage or hit trauma happened to the side, outside. It damages the common peroneal nerve. they get foot drop. Okay, damages to the common peroneal nerve. They always love giving the scenario and asking you what nerve is responsible. Okay, it's inverted and plantar flexed at rest. So when you take the foot, this is plantar surface, this is the dorsal. Okay, so that's the idea, folks. That's foot drop. Okay, so you should know that. Next, I'm going to talk about this. Right, there is 3 big muscles. There's 3 big muscles that are in the butt. One is gluteus medius, gluteus minimus, and gluteus maximus. Okay, now we can only focus in this gluteus medius and gluteus minimus. Okay, now let's say I'm drawing the one side of the butt. Okay, so that, let's say that's one side of the butt. Now, when we take one side of the butt, we divide that into 4 quadrants. Okay, this is outside, lateral, and this is medial. Is everybody clear, folks? Now, when it comes here, right here, this is a nerve, what we call superior gluteal nerve, right there. That's your superior gluteal nerve. Okay, the superior gluteal nerve is right there. Because of the nerve is there, whenever we take an injection or any shots, the best place to take an injection is here. Upper and outer. Is that clear, folks? Upper and outer is the best place to get the injections. Okay. Upper and outer. Upper and outer is the best place to give it. Now, in case you go to a nurse and they didn't give you an upper outer, and let's say they graduated from Florida and they're going to damage a wrong nerve. Okay, so if they give a shot in here, that will damage superior gluteal nerve. Is that clear, folks? So that's the problem here. So if you get an injection in a wrong place, it can damage superior gluteal nerve. Are we clear, folks? All right. Now, what will happen if it damages? Now take a look at here. This is normal. Okay, let's focus on normal. We're not going to worry about the pathology. This is patient's left side. This is patient's right side. Now, if patient's left side to go up, they have to use the right side muscle to contract. So it's opposite side, it tilts the other side. Is that clear, folks? So if I ask you to stand up and stay on right leg and tilt your left hip, you will use the right muscle to tilt the opposite side. Is that clear, folks? That's basically it is. Okay, right? So if I ask you to stand up and stay on your right leg, but don't let the left to touch on the floor, you will elevate the left up. Isn't it, folks? So contraction of the right side gluteal muscle, elevate the left side hip. Is everybody clear, folks? Now imagine in here, what's happening? The patient is trying to elevate the left side hip, but it's keep falling down. Is that clear, folks? That means this side, right side, superior gluteal nerve is damaged. That's why they are not able to contract, because when the nerve is damaged, it will not innervate the muscle properly. Is that clear, folks? Okay, so always remember it's opposite side. Look at this. Iatrogenic injury during intramuscular injection to superior medial gluteal region. That's the key. So better place to do it is superior lateral quadrant, folks. Okay. Now, when you suspect a patient possibly damaged it, you will do a sign. They come with this called Trendelenburg sign. Okay. Pelvis tilts because weight-bearing leg cannot maintain the alignment of the pelvis through hip adduction. Lesion is contralateral, opposite side. Whatever the side is falling, the opposite side is the problem. Is that clear, folks? Always remember, if I want to tilt my left hip, I use the right side. If I want to tilt my right side, I use the left side. So it's always opposite. Are we clear, folks? All right. Let's do a question quickly.